Now the fatty liver, non-alcoholic fatty liver disease. A male 47 years, type 2 diabetes for the last 11 years. He has come to you with the complaints of the mild abdominal pain. He doesn't take alcohol. He is not a non-smoker. He is a non-smoker. Height 167, weight 98, BMI 35.3. Ecchathos nigricans is present. Examination of the abdomen shows an enlarged liver, which is firm, non-tender, with a rounded edges. Liver function shows ALT and AST values elevated to more than 3 times the upper limit of the normal. So what is the working diagnosis? See, 47-year-old, type 2 diabetes for last 11 years, come to you with the complaints of mild abdominal pain. So most of the times, no, our Kakinada people, they don't come for the mild abdomen, they take Omes. Mild abdominal pain, Omes or ranitidine. He doesn't take alcohol, he is a non-smoker. BMI 35, so obese, very obese. Ecchathos nigricans is present, that means insulin resistance is there. Abdomen shows enlarged liver, firm, non-tender, with rounded edges. ALT and AST, that is your SGPT and SGOT, are elevated to more than 3 times the upper level. So upper normal is 30, SGPT and SGOT. So we must be having more than 90 AST and AST. What is the working diagnosis? Here is the fatty liver. What investigation will confirm the diagnosis? Ultrasound abdomen. Now the fibroscans. Fibroscans are also available. What is the treatment? No drug is available. Only lifestyle measures. Only lifestyle measures. So dietary approach and good exercise. And here the BMI is 35. So maybe the bariatric surgery also will help them. Okay, their metabolic surgery. So before the metabolic surgery, good dietary approach, good exercise program. So fatty liver is also called as metabolic associated fatty liver disease. So now it is a part and parcel of the metabolic syndrome. So what do you mean by the metabolic syndrome? Diabetes, hypertension, obesity, dyslipidemia. So now the fatty liver is also added to that. So that is the 5th point. So wide spectrum of the liver disease is a simple fatty liver, steatosis, non-alcoholic steatohepatitis, NASH, cirrhosis. So what is the difference between steatosis and non-alcoholic steatohepatitis? So inflammation. Okay. So when there is an inflammation in the liver cells, it is NASH. When there is no inflammation, only fatty deposition, it is steatosis out of simple fatty liver. So in fatty liver without inflammation is steatosis. Fatty liver with inflammation is NASH. So once this inflammation started, it is irreversible. And as goes on, as a period goes on, it goes into a period of cirrhosis. And some of the cirrhotics will enter into the hepatocellular carcinoma also. So it is our duty to pick all these people at the level of steatosis itself. So steatosis is reversible one. 2 essential features is the non-alcoholic and accumulation of the fatty infiltration in the liver cells. So now this is a very big disease in Indian subcontinent. See, it is defined as hepatic steatosis, diagnosed either by the histology or imaging with macrovesicular steatosis in more than 5% of the hepatocytes. According to the histological analysis or by proton density fat fraction or more than 5.6% as assessed by the proton magnetic resonance spectroscopy or quantitative fat or water selective MRI with no secondary cause for the steatosis. So here more than the 5% of the cells are involved here. Fatty liver. So this is the spectrum. See, the first picture is the fatty liver. Then some stars are there in the NASH. So that is inflammation. And in the cirrhosis, total fibrosis, thickness, darkness. So this is all in the cirrhosis. And finally they will land up with the hepatocellular carcinoma also. See, if you see the graph here, one is the accumulation of the fat in the liver cells with no inflammation. So that is the simple fatty liver or steatosis. Next one is NASH. NASH means fat in the liver cells plus inflammation. So the accumulation of the fat in the liver cells, that is steatosis, as well as inflammation. So that is steatohepatitis. And after that, fibrosis, and finally cirrhosis, and they have forgotten another one, that is hepatocellular carcinoma. So that is possible. So this NAFLD is reversible one. If you allow this NAFLD to enter into the NASH, that is not a reversible one. That is a continuous and progressive one. So only the time will take. In some people, that may take 5 to 10 years to become the cirrhotics, and some people they may take 15 to 20 years to become the cirrhotic, and some people they may take 30 to 40 years to become the cirrhotic. But at the level of the NAFLD, we all will have a major role in identifying the fatty liver at this stage, and then implementing the dietary approach or your weight reduction and etc. It is one of the hepatic manifestations of the metabolic syndrome. I told you one of the basic defects is the insulin resistance. So metabolic syndrome, what is the root cause for the metabolic syndrome? Insulin resistance. Again, the same insulin resistance for the fatty liver also. So the most frequent risk factor for the insulin resistance is obesity, especially abdominal adiposity. See the picture here, normal. When they have the insulin resistance or the obesity, become the fatty liver. Then some genetics and some environmental factors. What are the environmental factors? What are all we discuss now? That faulty food habits, some etc. and etc. So then lead to the cirrhosis. Now India is having more hepatic surgeons, more than the cardiac surgeons now. Every big hospital, now liver transplantation, about 25 to 30 lakhs, maybe 15 lakhs. So all corporate hospitals in Hyderabad are having the liver surgeons, hepatic surgeons. So imagine the incidence of the cirrhotics or fatty livers, etc. in India. So the most common cause for the abdominal liver function test, 10 to 20% of the population. Imagine 145 crores of Indians. So about 25% of the population is having the fatty liver, general population. If you take the obese individuals, about 50 to 70%. Again, India is the capital for obesity, world capital for obesity. Okay, what about the children? 2.6% of the children are having the fatty liver. And then the obese children, about 25 to 50%. Now most of the children are obese. So see, the fatty liver starts from the childhood. So it is almost like very common disease. See, 17 to 32% of the urban population in South India, and 55 to 87% of those with the diabetes have been shown to have a fatty liver. Almost urban population 32%. See the global burden. India, South Asia. India is about 57.9%. What about the United States? 51%. See the Latin America, Argentina, etc. 56. Europe, 68%. Africa, 30% only. And then East Asia, 52. South Asia, India, about 57.9%. So we are no way inferior to any other countries when compared to the fatty liver is concerned. High risk groups, males more than the females, more diabetics, more dyslipidemia, abdominal adiposity, and obese children weighs more than 95 years, 95% for age and the sex. DD, the macrovesicular steatosis, significant alcohol consumption, Hep B and Hep C, some drugs like methotrexate, hemochromatosis, autoimmune hepatitis, Wilson's disease, lipoatrophy, so starvation and parenteral nutrition. When the microvesicular steatosis, you have the Reese syndrome, valproate, ART, antiretroviral therapy, acute fatty liver of the pregnancy. So these are inborn errors of the disease, So they are very common. Clinical features, more than 90% are obese, 35 to 50% have acanthosis nigricans, 35 to 50% have enlarged liver, which is usually non-tender, dragging sensation of the upper abdomen. When the liver is palpated, it usually feels normal. When very large amounts of fat accumulate in the liver, it can become quite large with a soft rounded edge, which can be easily felt. So you should develop the art of seeing the hepatomegaly. So that helps a lot. So other comorbidities: hypertension, diabetes, dyslipidemia, sleep apnea, snoring. Diagnosis of the non-invasive tests. Status ultrasound is the preferred first-line investigation. MR is the gold standard, but more expensive. If imaging is not available, scoring systems such as fatty liver index, steto test, fat score test can be used. No non-invasive test can reliably distinguish NASH from the stetosis. So biopsy is required. So for a tissue diagnosis, for biopsy is required. Biomarkers and scores of the fibrosis along with elastography are acceptable non-invasive tests in patients at low risk of progression to the cirrhosis and the fibrosis. These tests are not as reliable in advanced fibrosis and cirrhosis and need confirmation by the liver biopsy. ABDA score. A stands for ACE, B body mass index, D diabetes either present or absent, and A your ALT levels. So this score more than 3.52 identified fibrotic NASH with 88.9% sensitivity and specificity. Biopsy is very much needed. See the histology. So this is the steatosis and this is the NASH and fibrosis. See, in all, exclude the secondary causes of the fatty liver. Alcohol is a very important cause. Steatosis is ultrasound, liver enzymes. When the steatosis is present, normal liver enzymes, serum fibrosis markers, low risk, etc. Options: lifestyle modifications, vitamin E, metformin, pioglitazone, GLP-1 receptor agonists and SGLT inhibitors, statins. So these drugs may help in arresting the further progression of the fatty liver.